Today I'm going to talk on tackling rare cancers, and I know that probably some of you or have either been diagnosed with a rare cancer or have a family member affected by a rare cancer, and you would have been confronted with the problem of A, what is the optimal treatment, and B, is there anyone I can talk to about this, and C, are there any clinical trials or new therapies that are available to me. And so really now we look at rare cancers almost as not so common, because collectively they actually contribute to a significant proportion of cancer diagnosis in Australia, and they contribute to a significant amount of morbidity. So I'm going to try and tackle this huge topic. I won't be obviously talking about each individual rare cancer, their treatments and their outcomes, but I'm going to give you an insight into the approaches or the approaches that are emerging that are going to tackle rare cancers not specifically with a one-size-fits-all, but with a more targeted approach. Just to frame the talk, 1 in 2 males and 1 in 3 males will be diagnosed with a cancer by the age of 85, and that includes your standard skin cancers. And by 2020, 150,000 new cancer cases will be diagnosed that year. Now, what's driving this increase in cancers? Well, basically, we know that cancer increases, its incidence increases with age. So you can see at the down here that when you're in your younger years, that the number of cancers is low, and then as we get older, when you look at, say, the 50 to 54 group, which is very relevant to my particular issue, we're getting about 1,000 new cases per 100,000 of population. And as we get up here in the 80 to 84 range, there is a much higher incidence of cancer. And of course, Australia and many other developed countries, we are an ageing population. But there is some good news. Although the rate of cancers is increasing, so this is the number of new cases is increasing to around 500 cases diagnosed per 100,000 population. If you look at the mortality, the rate of death to cancer, that rate is falling, which means that in the 80s, your chance of being alive at 5 years was around 50%. These days, it's more around the 70% when you take all cancers collectively. So there are a number of reasons why the mortality is falling. But before we go into that, let's look at the 10 most common cancers to frame what is a rare cancer. So we know that prostate, bowel and breast and melanoma in Australia are the top 4, then followed by lung. A rare cancer is defined as a cancer that occurs in about 6 people within 100,000 of the population per year. And to give you a reference, bowel cancer is about 60 per 100,000 per year. Then there's another group we call less common cancers. So they are those that occur within 6 to 12 people per 100,000 per year. And then when you look at rare cancers themselves, we have over 100 rare and less common cancers, all presenting at different stages, early stages, late stages, and the various diagnoses. And here are an example of some of the rare and less common cancers: brain tumour, thyroid cancer, male breast cancer, which occurs in about 1 male to every 100 women diagnosed with breast cancer, sarcomas, which are tumours of muscle and tissue, bone, neuroendocrine tumours, gastric cancers, pancreatic, gallbladder, kidney, testicular, Merkel Cell Carcinoma, which is a very rare but aggressive skin cancer, which I'll be talking about, and cancer in pregnancy. Now, when you look at common cancers, you can see that this graph looks at the percentage of increase in incidence, so the number of new cases diagnosed versus the number of deaths, and looking at population. Now, if you look at the population increase, there is an increase in cancers diagnosed, but look at the mortality. It's low, and it's separating away from the incidence, which means we're doing a better job at curing these cancers. But here's the problem. When you look at rare and less common cancers, here's your population growth over time from 1992 through to 2008. Here is the increase in rare cancers, and here is the mortality. So we've got a problem here. We're doing better for common cancers, not doing so well for rare cancers. And here is an impact. So prostate cancer, for example, we have about 20,000 new cases diagnosed. And if I take you down here to prostate, the mortality, it's 3,000. So the majority of patients will either be cured or will succumb to other causes, but not their prostate. When we look at rare cancers, when we put all the rare cancers together, in Australia, we get about 44,000 new cases per year. So it almost dwarfs single prostate cancer or breast cancer. But when you look at the survival is not so good. We have about half or less than half, about 24,000 that succumb to it. So we want to do better. So in summary, in terms of the magnitude of rare and less common cancers, rare cancers collectively account for about 30% of all cancers in Australia. They account for about 30% of cancer deaths. And the optimal treatment is often unknown, and there's often limited clinical trials to guide the management. So that is the issue that we're facing with in terms of rare cancers. Now, the media would make you believe that there is a medical or a cancer breakthrough daily. The reality is that there are breakthroughs, and there are significant breakthroughs, and I'm going to show you a few of those. But really, improvements in the survival of cancer, as I've shown you, is often incremental, and it's a range of things that we do that improves the cure rather than one magic bullet or one magic breakthrough. And what I'm going to do now is walk you through what are those steps that we take to incrementally improve the outcomes of cancer and how they relate to rare cancers. So, we actually use a range of approaches in tackling rare cancers. The first of these is the collection of database. Now, some of this does apply to normal cancers, but it's particularly important for rare cancers because we need to collect the data. So, databases, and I'm going to show you an advantage of how databases help rare cancers, is important. Multidisciplinary care. Many of you, or some of you who may have been diagnosed, will have been exposed to multidisciplinary care. I'm going to show you how that helps rare cancers. Clinical trials, personalised therapy, such as targeted therapy, immunotherapy, and finally raising awareness. Community awareness to lobby governments for funding for research is critical. So let's start by looking at the importance of databases in rare and less common cancers. So Merkel Cell Carcinoma is a very rare skin cancer. So many of you would not have heard of it. It's very aggressive, more aggressive than melanoma. One of the problems with Merkel cell is that it has a high propensity to recur even after you've treated it with either surgery or radiation. It also has a high propensity to spread to other parts of the body. And because of its rarity, we don't know what the best treatment for it is. If you were to wait for a Merkel cell and then work out how you've treated it, and then work out, well, this was good, I'll treat this the next time in a similar manner, there may be 3 or 4 years before that interval. So you can imagine you're not going to make any significant gains over your lifetime. But collectively, using databases, we can see what's happening. Interestingly, so looking at Merkel cell, the rates are very low, which also means that even in countries like the US, it occurs in less than 0.6 per 100,000 in the US. In Queensland, where I'm from, it has the highest rate in the world, and even then it's 1 patient per 100,000 population. So you can see how long it would take to, if you were doing it as a single practice, to work out what the best treatment is. But here is how databases help. So this is a database from America. It's called the SEER database, and it collects cancer diagnoses, treatments, and outcomes. From 1973 to 2002, data for Merkel cell was collected. And what it showed was that over time from diagnosis and the survival, this is a survival curve, and it shows that the patients who received radiation after their surgery for Merkel cell survived better. There were fewer deaths in those that received radiation compared to those who were simply treated by surgery alone. So while we didn't do a clinical trial, we were able to identify from the SEER's database that patients diagnosed with Merkel cell, this very rare aggressive skin cancer, do better if you combine surgery with post-operative radiotherapy. Now, the importance of multidisciplinary care can't be understated. In 2004, the National Service Improvement Framework for Cancer, which is a joint initiative of the Australian Government, states and territories, identified that a more coordinated approach to cancer is required. What we're saying here is, rather than seeing one specialist moving to the next, then moving to the next for a diagnosis, a treatment, and subsequent management, needs to be better coordinated. And when you're dealing with a rare cancer, as some of you may have experienced, going from one clinician to the other only creates greater confusion because you get mixed messages. But what about if we could bring everybody together and make the treatment more patient-centred rather than the patient being sent to individual specialists? And so our model of care these days for cancer is multidisciplinary care. And I'm sorry if some of you already have heard this many, many times, but it really has impacted on the way we manage cancer patients. So the model is patient-centred care, where the patient is in the middle, and then we have a range of specialists, nursing care, allied health care, data managers, researchers, etc., all coming to the one centre. And what does this do? Well, the benefits of multidisciplinary care show that it improves the sort of care plan, the agreed treatment plan. In other words, the patient is receiving a consensus rather than a whole range of opinions. It forces the clinicians in the room to deliver an evidence-based medicine approach. In other words, taking the best available evidence. Now, sometimes that available evidence is not there, but when it is, you want it to be applied. You want to know that no matter which multidisciplinary care centre you go to or whoever you see, that you're getting evidence-based medicine. And MDTs adopt that approach. It has been shown to improve patient satisfaction, and it streamlines the sort of whole pathway from being diagnosed through to treatment. And it does result in a reduction in duplication of services. Importantly, it doesn't matter whether this is done in the public or the private. The important aspect is that it's multidisciplinary. And how does it work? Well, here's some evidence that shows that multidisciplinary care improves outcomes, and it's very important in a situation where you've got rare cancers. So this is a British study that looked at hospitals within a various region. Now, what this shows is survival, okay? Now, in this particular region, there was the survival of patients being treated in that region for breast cancer was improving. So over time, it was improving from 1990. In 1995, there was another region that wasn't doing so well and didn't have multidisciplinary care. In 1995, they took the approach at about here to intervene by using a multidisciplinary approach. We call this the intervention area. When they introduced multidisciplinary care in 1995, the survival for patients treated at that region for breast cancer improved such that it actually surpassed the non-intervention area, showing that the multidisciplinary care, for all the reasons I've described, actually improves your outcomes. Now, it's hard to do a randomised study these days, in other words, taking people, treating them outside multidisciplinary care and inside multidisciplinary care and seeing who do better, because that's it is unethical. Now, the other thing is about rare cancers is the more we treat, the better we get. Now, one of the things about rare cancers is I've mentioned that the frequency of seeing patients is problematic because you don't see a lot, so you can't treat a lot. But one way of overcoming this is by using clinical trials to measure your outcomes. Now, this study, which was done in the US, was a study that looked at patients who were enrolled in a head and neck cancer radiotherapy trials, which is the area that I treat. And they took patients and treated them on the trials, and then they looked at the centres that only did a few patients on the trial, and they looked at centres that were doing a lot of head and neck cancer work. And then they wanted to see what were the outcomes. In other words, does treating more mean you do better? And what it showed, this is also a survival curve, and what it showed was that this HHAC means high accruing centres, and this is low accruing centres. So this is low accruing centres to the clinical trial. And what it showed was that if you were treated on the clinical trial in a centre that treated a lot of patients, your survival was better, compared to if you were treated in a centre on the trial that didn't do so many. They went, I won't give you all the details of this trial, but they then went back and looked at, well, is it the quality of the treatment itself that makes you, gives you a better outcome? And the answer was that, yes, the quality of the treatment, but there were other things at play. And what they really found was that it wasn't just the actual technical treatment of the radiotherapy that improved your survival. It was the care that you were receiving during the treatment, the management of the side effects, the management of the complications of the treatments. So in rare cancers, you can imagine that's incredibly important. Although they're few, you're better off being treated in a centre that is seeing, well, the evidence suggests that seeing a lot or doing this more frequently. And we apply this to all other cancers, of course. And then the importance of clinical trials. So if we can get enough clinical trials for rare cancers, then what we should be able to do is help create the evidence and promote evidence-based care. What I'm going to show you now is really the clinical trial landscape in Australia, and I'm going to show you the importance of clinical trials, not just in rare cancers, but in all cancers. So enrolment into clinical trials promotes evidence-based care. It improves outcomes. It helps us answer questions using large-scale, multi-centre prospective studies. What that means is no one centre will ever be able to answer questions on something that is rare. But combining the power of multiple centres helps us create the sample size to detect a benefit in a treatment. What it also does, it means that if you go to see Dr. X, you're going to get the same treatment by enrolling on a trial than if you went to Dr. Y. And this can often be problematic if you're coming from the community, never had a diagnosis of cancer, never had much to do with the medical system, and then finding that you go to one person and get one treatment or one treatment recommendation and another treatment recommendation by someone else. It creates two dilemmas. The first is which of the two treatments are better, and which how do we know that the treatment of a Dr. X is, it's the same, it's going to be superior in the long run. It helps us also monitor what's actually happening, and it helps address rare and less common malignancies. Now I'm going to show you how that helps in the context of the Australian landscape. So as you know, in Australia we have the tyranny of distance. We also have the issue of people being isolated, and so it can be difficult to run clinical trials. And then when you look at the world population, we don't even rank at all in this graph. Europe having 500 million, when you look at Australian population of 23 million, which falls below here, and then compared to the Chinese population of 1.3 billion, you could see how doing a clinical trial in Australia addressing a rare cancer is difficult. But we can do it. I'm going to show you how. So some of you may have heard of what's called cancer collaborative trials groups. So these are cancer trial groups that have a common theme. So we have about 14 of them in Australia. What they do is they have a set of protocols, they conduct clinical trials, and they monitor those clinical trials. So for example, we have the Australian Sarcoma group. Sarcomas is a rare cancer, and this group conducts clinical trials into sarcomas. I won't go through them all, but my group is the Trans-Tasman Radiation Oncology group. That's the group I chair, and I'm going to show you how we were able to answer at least a question in Merkel cell. So as I said, in Merkel cell, 1 person per 100,000 is diagnosed with Merkel cell. We did see from the SEER's database that there was some advantage of offering radiation to patients with Merkel cell. That helped controlling the disease locally where it occurred on the skin, but it didn't help patients where the Merkel cell had spread to things like the bone and the lungs. And so we wanted to know, well, can chemotherapy help? The first obstacle, though, was getting enough patients. And what we found was that through the Trans-Tasman Radiation Oncology group, we were able to conduct a trial that gave us some meaningful data. This is the survival curve, but essentially what's important here is that we were able to show that you could collect enough patients using this collaborative trials group to look at some data in a very rare cancer. And it showed that chemotherapy can be delivered in a multi-institutional trial setting, that the outcomes were better than historical, and that the side effects are acceptable. We would not have been able to do such a trial in the absence of collaborative trials groups. And finally, in terms of building up the argument of the approaches that we're taking, the quality of the treatment is very important. The TROG group, my group, did a study that we looked at the quality of the radiotherapy when you're on a clinical trial. And it showed that, this is the survival, it showed that if the radiotherapy complied with the protocol, your survival was much greater than if you had major protocol violations. In other words, you weren't following the radiotherapy protocol. And that survival difference was 20%. In other words, the quality of the care that you're receiving is paramount to the outcome. All right, I'll skip that. Okay, so now I've told you about the issue of rare cancers, that it is collectively an actual big number. It represents 44,000 patients in Australia, that the cure rates are not as high as other cancers, and that we have a number of ways in which we are seeking to improve the outcomes. Not all of them are with one single magic bullet, but it's a number of approaches: databases, multidisciplinary care, treating in high volume centres, looking to enrol in clinical trials, because clinical trials delivers you evidence-based care. And I've shown you briefly that there's evidence that the quality of the care that you receive improves your outcome. So now what I'm going to do is cone down on some of the treatments that we have. Now, it's challenging and difficult to talk about each individual rare cancer and what the best treatment is for that particular one. But what I'm going to show you now is the general approach that we're taking, that for you or a family member that may have received treatment, I'm going to show you the principles behind those approaches. The good news is that some of these approaches, particularly the last one, which is immunotherapy, is, I believe, going to revolutionise the way we treat rare cancers, because it's not we're going to manipulate, as I'll show you, the body's own immune system, rather than pouring in what we generally do is give you toxic agents. So some of you may have heard of the emergence of personalised care. What I'm going to do now, for those of you who don't know what it is, I'm going to show you the approach of personalised care or personalised medicine. And I've as you can imagine, I'm dealing with a broad audience, so I hope I'm going to manage to explain it adequately. Okay, so the human DNA is the genetic blueprint that controls us, that drives us. We turn on genes from the DNA that promotes proteins that drive our system. We also have genes that control other genes and control whether genes should be turned on or turned off. So there's a massive interplay. Now, when we take a section of DNA, sections of DNA form genes, these genes produce proteins which control the body's function. Now, these genes may be turned on or they may be turned off, or they may actually be overproduced or underproduced. So what happens is you're getting too much protein, or you may not be getting enough protein to drive the system. Now, a collection of genes, so a whole series of them, not just one, but a whole series, may be turned on in one cancer and may be turned off in another cancer. But this is the important point. When you look at the way we treat patients, you might come in with a thyroid cancer, and we say, thyroid cancer, we will give you drug X or treatment X. But the reality is that thyroid cancer that one patient may have may be expressing entirely different genes to another patient with thyroid cancer, which means that one patient may respond to the therapy if they've got the right genes turned on and off, or they may not respond if they've got the wrong genes. Personalised medicine now looks at this collection of genes and tries to form a signature. So, for example, you might have gene A, B and C turned on, and you may have gene D, E and F turned off. And then we aim to treat accordingly. So here's how it works. So, patient comes in with tumour X. This is a tumour that's growing, and we do a gene analysis of that patient's tumour. It doesn't matter whether it's a melanoma, a brain tumour, whatever. It's tumour X as far as we're concerned. We're not going to differentiate it, but simply in that sense, we're going to differentiate it in terms of its genetic makeup, what it's doing. This is what's called the expression of genes. This is a way that we can see if genes are turned on and turned off. I don't want you to get too involved in what this actually is, but if you like, this is the signature that we're looking for. And then we take drug A and we expose it, and we found that when you had this signature, melanoma, breast cancer, thyroid cancer, whatever, when you had this signature, you were responsive to drug A. So what we do now in personalised medicine, and we're not there yet, we're still evolving it. There are aspects of personalised medicine, but it's not totally routine yet. So then when tumour Y comes along, rather than looking at whether this is a thyroid or a breast, we want to know what is the gene signature here. If the gene signature is the same as this one, and we knew that when you've got this signature you are responsive to drug A, then the plan will be that we'll treat you with drug A. So it didn't matter where it originated from. What mattered was what it looked like, what its gene signature was. And there's a trial that we're about to open in Australia that is actually going to look at head and neck cancers, and we're going to look for what's called a hypoxic gene signature. So we're going to look at whether certain head and neck cancers have this gene signature, and if so, we're going to expose them to a drug called nimorazole and look at whether that nimorazole, so we're looking at this step here. So we're going to look at this gene signature, we know what we're looking for, and now we're going to test whether they're responsive to drug A. And in my case, it's going to be a drug called nimorazole, which is used for, believe it or not, it's an anti-dandruff medication. All right, so now I've shown you what the notion of personalised care is. Now what I want to do is cone down now on actual treatments which are kind of personalised care. Not quite 100%, but heading towards that. And that is targeted therapy. Okay, so this is a little complex, and I'll walk you through this. So I'm going to show you now how targeted therapy revolutionised the outcomes for a very rare cancer known as GIST, gastrointestinal stromal tumours. So, for tumours or cells to survive, they need to be switched on through a series of proteins. The analogy here is you're driving a car and your foot is on the pedal. To move that car, you need your foot on the pedal. Now, to get the foot on the pedal, you need some muscle. And so what happens is, so these proteins use a phosphate group, we'll call it the muscle, to switch on or press down the foot on the pedal. Now, normal cells will know when to switch on and switch off their proteins. In other words, if you're driving your car, you'll know when to take the foot off the pedal, when to put it down. Cancers will lose that ability. They will just keep the foot on the pedal. And so what happens is there's this constant drive, there's ongoing replication of cancer cells. They then enlarge, they cause a local problem, and then they eventually can spread. Now, we can actually, if you like, take the muscle away, block the activity of the muscle. And so here, what we can do is block the activity of this phosphate group through what's known as a tyrosine kinase inhibitor. We'll call it TKI. Now, in gastrointestinal tumours, GIST, which is a rare cancer arising from the gut, it's commonly associated with a particular mutation, but this mutation within the genes, but interestingly, this mutation codes for this tyrosine kinase inhibitor, this protein. Now, imatinib is a TKI, and it was approved in 2002 for the use for GIST. And what it did was it turned the survival of someone diagnosed with GIST from about 9 months to 20 months, the average survival, to 5 years and beyond. And I've got one patient who's had GIST for 20 years. So it's taking a cancer, not necessarily curing them, but turning off various proteins, taking the foot off the pedal, so that you still survive with your GIST, but it becomes more of a chronic condition. As we know, though, many drugs will cause long-term or ongoing side effects. One of the advantages of imatinib, however, not being a chemotherapy agent, was that the side effects are essentially lower than systemic chemotherapy agents, with it's said to have minimal lifestyle impact, and certainly the few patients that I've got on GIST have managed quite well on long-term imatinib. I'm not going to talk today about the costs of these drugs and the ongoing expense, but really I want to talk about the clinical efficacy of these. So here's a way that we've converted a rare cancer into a chronic illness rather than short survival. Now, this is the area I'm going to finish off on, apart from the supporter group, which is really, for all of us, going to revolutionise the way we treat and view cancers. And that is the emergence of immunotherapy or immuno-oncology. Because what we're going to do now is we're going to use chemotherapy, we're going to use targeted therapies, but now we're also going to enhance the effects of the immune system, because we now recognise quite nicely that there is a strong interplay between the immune system and cancer. So, cancer immunotherapy is a new anti-cancer therapy. I'm going to show you an example of those. There are many more in development, and even in these early days they're showing long-term remission. Why is this important in rare cancers? It's important because when you've got individual cancers, the problem is that you're going to have to test hundreds and hundreds of newer therapies to improve outcome, whereas with immunotherapy it doesn't matter what the rare cancer is, it's really about tweaking the immune system. As we know, we have an immune system with white blood cells, and we have things called B cells and T cells, generally there to help fight infections and get rid of foreign bodies. If you have a bacterial infection, the B cells get excited, they produce antibodies that direct towards the bacteria and kill it off. T cells tend to be useful for viruses, and I'm going to show you why there's an added benefit for virally mediated cancers. But T cells help generally fight infections, mainly viral, but also bacterial and other foreign bodies. And these cells that help make up the immune system can be found in the lymph nodes, they can be found in the blood, they can also be found in just the normal tissues such as your gut. Now I'm going to show you how the immune system and the cancer interplay, and then I'm going to show you some of the drugs we're using. So, here is a tumour, here is a lymph node with the T cells. There's a cell in the immune system known as the dendritic cell, or the other name for it is antigen-presenting cell. What it does, it takes some information off the surface of the tumour and delivers it to the T cells like this. The T cells, this is what also happens in infection. The T cells then look at that antigen, the information that's come from the tumour, and it starts to activate and mount a response. So it then goes across to the tumour, and it's got this sort of interlocking, recognition that, okay, on the surface it says, I'm going to now seek out tumours with this message that I've already received from the antigen-presenting cell, and it kills off the tumour like it does with an infection. So that's the process. The balance here is that if you can mount a sufficient immune response, then you can outweigh the cancer and you can get rid of the cancer. We haven't used any chemotherapy agent here to kill a single cell. We've used the immune system. However, if we can't mount an effective immune response, then what happens is that the cancer overrides us, and the immune system and the balance sways in favour of the cancer. So when you look at that, you think, okay, well, can we drive this? Can we mount a better immune response so that each time we outweigh the cancer? So when a T cell, remembering this is the thing that helps kill the tumour, when the antigen-presenting cell locks onto the T cell, so the antigen-presenting cell is the bit that took some information off the tumour and told the T cell, this is what it looks like, go and seek it and kill it. The problem in the normal system, this has been designed for infection. You don't want the immune system turned on all the time because you'll start to attack yourself. So it has a mechanism, so this is when it's activated, but it has a mechanism between the antigen-presenting cell and the normal T cell to turn it off at some point so that you don't drive the immune system. This is under normal circumstances. And this is a thing called CTLA4. This is the message between the antigen-presenting cell and the T cell, and the CTLA4 finally says, enough's enough, we'll stop mounting this T cell activation. Now this is where we come in. What if we were able to take a agent that blocks this CTLA4? In other words, we take away the stopping of the T cell activation and prime the immune system to attack the cancer. And in fact, so the superactivation here. In fact, so what you're doing is at this lymph node stage, you want to turn off this activation. You want to allow this to keep going to kill the cancer. Like that. And in fact, we have an agent. Here is a very important paper that showed these are patients with advanced melanoma, and here is a melanoma deposit in a lung, And here is resolution of that deposit following exposure to the anti-CTLA-4. And here is a number of spots that have disappeared, and here is a spot on the brain which has disappeared after CTLA-4. Now, I know I'm talking about melanoma here mainly because that's where most of the work has been done, but this process is applicable to other cancers, including rare cancers. So Ipilimumab in 2011 was licensed for the use in advanced melanoma. Now, it's not without its side effects. It is driving the immune system, and then you can start to attack its own body, and so we're just still working on finding the balance between that. And I'm going to show you now how this immunotherapy has added to the benefits of cancer care. So here is a group of patients with advanced melanoma, and advanced meaning it has spread to other parts. And we would traditionally give patients chemotherapy, and your 1-year survival would be about 30%, your 2-year survival about 10%, and then your 5-year survival about 40%. When you add Ipilimumab, this anti-CTLA-4, after chemotherapy, which is what it's used for, you improve the survival, chemo and Ipilimumab, to 50% 2-year and 5-year survival to 20%. So we're taking now a condition that had a 4% 5-year survival to 20%. Now I'm going to show you the latest breakthrough, which really only has just emerged in the last 12 months. Okay, so we understand that if we can block the effects of what we call downregulation of this interaction, in other words, we want to keep driving it, there's actually another side, and that is when the T cell goes back to the tumour starts to tell the T cell, back off. What we've found now is that there is an interaction here called the PD-1. And if we could stop the tumour from telling the T cells to back off, we can override another part of the immune system. And we actually have a drug called pembrolizumab, which we abbreviate to, or we just call Pembro. And now I'm going to show you, so here is the chemo, then you get the Ipilimumab, and here is pembrolizumab. So what happens now is that when you add pembrolizumab, so attacking another part of the system, 1-year survival is now 70% compared to 30 and 50. 2-year survival is now 50%, and 5-year survival is 40% and beyond. So we're now converting what was a poor survival condition to a chronic condition. And we now, amazingly, have lots of long-term melanoma survivors through this mechanism. This pembrolizumab is now making its way to a whole range of cancers. And that's the schematic. So now most of the research has been done in lung and melanoma, but now we're attacking rare cancers, lymphomas, brain, head and neck, gynecology, a whole range. And this pembrolizumab is being used in a wide range of cancers. The beauty here is it doesn't matter what your rare cancer is, because it's really about the host. It's about changing the interaction between your own immune system and the tumour. And here is really just to show you, don't have to look at this, but it's just to show you that we are now looking at these drugs in a whole range of cancers. And finally, about viruses and cancer. I remember a patient of mine many years ago saying, "Can I catch a cancer?" And I thought, "You're crazy." But look, there are lots of cancers that are mediated by viruses and other infections. And here I've listed a few. Now, the reason I just want to mention this is because the thing with viruses is they play beautifully into this whole immune thing, because viruses will express something on their cell, and then the immune system is very good at detecting that signal and then mounting an immune response. And we can manipulate that. In fact, one of the trials that I'm involved with, which is nasopharyngeal cancer, which is caused in many cases by the Epstein-Barr virus, the same virus as glandular fever, we can now take patients' blood, look for the virus signal which is found on the cancer cells, outside the body manipulate the T cells to mount a response, and then re-inject the patient's own serum to attack the cancer. So it's all done without any drugs. And finally, to finish off, rare cancers is an important, collectively is an important issue. But because they're all individual, if you look at the research funding by cancer in Australia, as I said to you, a large proportion, 30% of cancers are rare cancers, 30% of deaths are due to rare cancers. Yet the research budget, which does drive improved outcomes, is only 13%. How do we overcome this? We overcome this through various organisations that help raise awareness, lobby cancer councils. Here, the organisation I'm involved with, the Clinical Oncology Society of Australia, which is the cancer-related health professionals organisation in Australia, held an entire conference on rare cancers in November in Tasmania of last year, raising the awareness amongst clinicians and other key policymakers about the importance of rare cancers. And we do have supporter groups in Australia. Rare Cancers Australia is also a group, and I invite you, I'm not affiliated with them, but I invite you to visit their website. And so tackling rare cancers is a multi-pronged attack. We do have some major breakthroughs, which I've shown you, but many of the improvements are often small, incremental, using a range of modalities. And with that, I'd like to finish and acknowledge Professor Patel Pullen for some of those immunotherapy slides, and Richard Vines from Cancer Australia for from Rare Cancers Australia for some of the data. So thank you very much.
Okay, folks, here's your chance to ask questions. I will ask you to put your hand up. Because we're recording this, we need to capture your question on the microphone, so if you could only ask your question once you've got your microphone in your hand, that would help us for other people who might be listening to this later on via the web or other means. So, any questions for Sandra?
Is there any relationship between cancers and people with autoimmune diseases?
Absolutely. So, our understanding of the immune system and cancer has been growing exponentially. We've recognised that there are a number of autoimmune conditions, Sjogren's, Crohn's disease, various bowel conditions, thyroid conditions, where these people tend to have a higher rate of cancers. We've never really fully understood it properly. We've just recognised the association. But we now recognise that what is happening is cancer is in itself an immune suppressive condition. In other words, it suppresses the immune system. So any condition where the immune system is not functioning well is a great sort of environment for the cancer, because it's learning to escape the cancer. But there's no doubt now that we understand that if you have a very good immune system, we're probably developing small cancers all the time, but we're managing to eradicate them before they overcome us. That sort of balance I've shown you.
If you wanted to find out if there was any new work being done on a specific rare cancer, is there any way that the general public can access any of these databases to see what's being done with that particular cancer? Yeah, so in Australia there are various clinical cancer trials sites. So if you went to clinicaltrials.gov, you will find some of the trials that are out there. The Americans have a group that actually have their own specific rare cancers group, the RTOG. And you can look up the RTOG. I've shown you a slide with their emblem. And they have their own rare cancers group, so they've got a number of trials that are open. One of the things that I mentioned really at the
the end very quickly was this supporter group, say something like Rare Cancers Australia. Now, I'm not endorsing them, I'm just using them as an example. We need robust sort of supporter groups like that to actually bring in that data so that you could go to somewhere like Rare Cancer Australia and find that. Cancer councils obviously try and do that. The problem is that being rare, there aren't a lot of clinical trials. I published once a series of 7 patients on a rare condition known as SNUC, sinonasal undifferentiated carcinoma. After publishing that series of 7 patients who I treated all the same, I became the world expert. People were writing from everywhere. The problem with the rare cancers is the lack of clinical trials. But there are some, and trying to bring all that information is good. Clinicaltrials.gov and also the RTOG as a website. And I would encourage us to get together and form supporter groups to bring all that information together so you can go to just one site.
Howdy. It sounds exciting, pumping up the immune system to do it naturally. But again, getting back to the autoimmune diseases, there's an awful lot of them around. If you pump up, which is your own immune system attacking an organ, if you pump the immune system up, will that further attack?
So it's not a case of volume. What I mean here is if you drive up the immune system, it doesn't mean you're going to develop an autoimmune condition. What it is the immune system's not working properly. In other words, an autoimmune condition, what happened normally in a normal immune state, we can recognise self and we can recognise non-self. The immune system in autoimmune conditions has lost the ability to recognise self. So even if you drive it up, it may not drive a massive autoimmune response to your own body. What I'm saying is that driving the system isn't that you drive everything globally. You might be just driving one element of the immune system. So the T cells are only being turned on to attack tumour, not to attack the body. And you're teaching it to attack the cancer.
Folks, I will wind it up there. Thank you very much for coming along. If I can just do a few things before I ask you to thank Sandro for what I thought was an extraordinary presentation. It's worth you understanding that the concepts that have just been presented, firstly, are really quite new, and secondly, are very, very complex. And that's the most erudite description of that I've certainly seen. So it's worth you appreciating that what you've been treated to is, what I found at least, an extraordinarily powerful and useful presentation. So please, if you could fill in your evaluation forms, if you're interested in more of events of this kind the Cancer Council run, we do lectures and events of all kinds. You can add your details to the evaluation form. That's by your choice. You don't have to by any means, but if you'd like to hear more, that's a way of you doing so. And again, if I can remind you, this presentation will be available on the web. And of course, there's usual information sources through the Cancer Council and our cancer helpline, 13 11 20. But in saying so, please join me in thanking Associate Professor Sandro Porceddu. Thank you. Great job.